Welcome everyone, and thanks so much for joining today's webinar. Today we have Doctors Krista Harrison, Sarah Garrett, and Alissa Bernstein with their presentation, Data Collection, Analysis, and Dissemination in Dementia Palliative Care Research, an Interdisciplinary Qualitative Approach. Just a couple of housekeeping items. All attendees are muted and video cannot be turned on. We also ask that you please use the Q&A feature to type in any questions, and if you're feeling up to it, feel free to use the raise your hand feature and ask your question out loud for our panelists. Please share your questions and comments at any time, and we'll have time throughout today's webinar and also at the end to answer all questions. We also have Dr. Christine Ritchie, co-chair of the PCRC and representing the PCRC's executive committee. So I think we'll get started, and I'll ask Christine to please introduce our speakers.
Greetings, everybody. I could not be more delighted to introduce our speakers today, who are wonderful colleagues and truly experts in their field around qualitative data analysis, and you will learn so much today. So I'm excited to be able to introduce them to you. Our first speaker is Sarah Garrett. Dr. Garrett is a medical and cultural sociologist, and she's currently a health policy fellow at UCSF's Philip R. Lee Institute for Health Policy Studies. Her work has spanned multiple areas, including individuals' experiences with and navigation of maternity, oncology, and dementia care, and methodological work on the conduct and communication of qualitative research. She co-directs the Medical Cultures Lab, which is a group of primarily qualitative social scientists who are interested in the culture of medicine. Dr. Alissa Bernstein-Seidman is a medical anthropologist and health policy researcher who's focused on understanding and improving the assessment, diagnosis, and care of people with Alzheimer's disease and related dementias. And she has a specific focus on primary care and safety net settings. She also conducts research focused on care navigation to support people with dementia and their caregivers, and building palliative care approaches in memory care settings. She's an assistant professor and also a core faculty in the Philip Lee Institute for Health Policy Studies, and was a faculty, or is a faculty, in the Global Brain Health Institute at UCSF. And last but definitely not least, Dr. Krista Harrison is a health policy, bioethics, and health services researcher who focuses on improving systems of geriatric palliative care for home-dwelling older adults with dementia and other serious illnesses. She's a former hospice administrator and currently an associate professor in the UCSF Division of Geriatrics, where she holds several leadership positions, including associate director for the Geriatrics 232 program there. She's affiliate faculty in the Philip Lee Institute for Health Policy Studies and an Atlantic Senior Fellow through the Global Brain Health Institute. So let me ask each of you then to tell me a bit about yourselves as it relates to your research, and specifically about sort of this research and how it relates to your specific interests. Why don't we start with Dr. Harrison?
Thanks so much for having us today. So one of the reasons that we wanted to share with you today was that we had the pleasure of collaborating on a mixed methods research project on dementia palliative care. And this is the only project that I've ever been on where we had 3 PhD trained qualitative experts, and each of us came from a completely different discipline. And so this has really been a fascinating experience of sort of uncovering what do we actually mean when we're talking about different concepts, and how are we thinking about approaching data collection and analysis? How do we think about dissemination? Alissa or Sarah, want to chime in?
Yeah, thank you everyone for inviting us to participate here. I'll just affirm what Krista said. You know, it's very unusual to work across disciplines, we think, with experts in different social science disciplines in this soft money environment. So I feel like we learned a great deal from each other. And we've done some record keeping around best practices and what we learned, and it's a treat to get to share that with a broader audience.
Yeah, and thank you everyone for having us. And yeah, I think we'll be able to share a little bit about both our different approaches, as well as some of the ways we found common ground by discussing the project we worked on together, as well as a little bit about some of the work we do independently. And hopefully it'll provide a range of kind of an understanding of the range of things you can do with qualitative research, and kind of how exciting it is as a method for complementing other types of research methods in clinical research.
Thank you. It's really fun to think about the fact that even though you all come from the social science community, you do have such different perspectives and different training and come from different disciplines. And that kind of intersection is very rich, and I think leads to rich interchanges. So I wonder, Krista, if you could start by explaining the overarching project to provide some context as we then get into the methods of these different analytical approaches.
Sure, I'd be happy to. So we conducted a mixed method study that aimed to understand needs and inform the development of palliative care clinical interventions in a specialty dementia center for people, and specifically for people living with dementia and their caregivers. We launched the study in 2018, completed data collection in 2019, and we continue to analyze and disseminate our findings. This was originally designed to be stage 0 on the NIH stage model for behavioral interventions. In other words, we were aiming to generate data we could use to identify which behaviors and actors might benefit from intervention, to inform the modification or adaptation of existing interventions, as well as develop new interventions. So I'm going to tell you about kind of 4 different sub-studies, one of which was a chart review of roughly 700 former patients at the Specialty Dementia Center, which did involve some piece of qualitative analysis of textual data in the charts. But that sub-study looked at completion of advanced care planning, loss to follow-up, and healthcare utilization among former patients. Another sub-study was interviewing patients who could consent for themselves, active caregivers, and former caregivers of patients who had died with severe or advanced disease. Sarah will say a little bit more about this in a moment. And as a side note, the 4 of us also worked on a related project that focused on similar issues among patients and former caregivers with sporadic Creutzfeldt-Jakob disease, in which 90% of people die within a year of symptom onset. And then the final sub-study that I'll mention that Alissa will speak more about was interviewing interdisciplinary memory care providers about their perceptions of palliative care needs of their patients, how to address them, and what training they would want to better address palliative care needs.
Thanks, Krista. That's a really nice overview of the various projects, and really highlights the value of sort of this triangulation approach, where you look at a number of different perspectives, all offering insights into a problem. And one of those perspectives were the memory care providers. So I wonder, Alissa, if you could just tell us a bit about the considerations and challenges that you experienced interviewing those memory care providers as part of this larger conversation.
Yeah, so maybe I'll mention a little bit about my kind of disciplinary orientation as it relates to this piece of the project. So I'm a medical anthropologist by training, and so our qualitative approach, which has been used also in sociology, is really to both embed yourself in and do field work with your research participants, and observation, spending time getting to know people, building rapport, and then also interviews and focus groups and things like that. But so with these memory care providers, I'd actually been embedded in their research and clinical setting for a number of years, and had really gotten to know people and understood the kind of dynamics of their clinical practice, and that really informed some of what kind of I did in the research context to understand how patients move through the clinic, what types of questions to ask them, how we developed the interview guide, and then really to kind of contextualize the responses that they gave during the interviews. So I did interview I think we ended up with 16 interviews with memory care providers, and asked them to talk about their both their current practices caring for patients who have dementia, and especially at the later stages as they're dealing with end-of-life issues, and then also ask them to reflect on the challenges that they face, where they think they're having, not necessarily, doing as well as they would like to do, and some of the things that they would like to improve their practice. And that's not always an easy thing for a clinician to talk about, is like, where they're, they're not sure if they're doing the right thing. And so I think, my relationships with these people before built a lot of trust to get to a place where, I think people were able to be vulnerable in their responses. And we got some really deep kind of responses about, not knowing what to do, not knowing how to talk to families about these difficult things, wanting to, diagnose and then just move on and things like that. And so there was really a depth there that I think the methodological approach brought, but then also, consideration about how to really sensitively portray what our participants talked about, knowing that they would be reading, reviewing, continuing to be colleagues with us throughout, through this project, and then, hopefully for the rest of my career. And so, really taking this kind of balance of, the ethics of research, of how do you portray people talking about what's challenging to them that might not, fit with this sort of vision of the doctor as knowing everything or the authority, and use that to kind of create guidelines or tools that could really improve practice, while being really sensitive to, sensitive and critical, I would say. And it's a fine line. And I think building that rapport in advance where they have the trust was a huge key part of that. And that, can be done with patients and caregivers as well, when you have kind of the time, which isn't always possible in qualitative research, to really spend with people and build that relationship. So I think it's an important kind of line to walk between, building trust and allowing your critical, mind to do what is needed to create an intervention that will be effective.
Those are really important points, Alissa. And I think just to reiterate that we don't often think about the value and the necessity of rapport building before engaging in qualitative interviews and qualitative work. And as we move more into thinking about community-based engagement and community-based participatory research, it's incredibly important for us to be engaging in relationship building and rapport building long before we start engaging in these kind of qualitative interviews. And I think your work highlights that. Thank you for sharing. So Sarah, tell us what kind of challenges came up for you in doing similar qualitative data collection with patients and caregivers.
Yeah, thank you, Christine. And I guess, inspired by your approach, Christine, they were challenges, but I think they were also opportunities for us to really refine, these moments where things were a little challenging. They were moments for us to refine our approach and do a better job than we might otherwise if it hadn't felt a little difficult. So I think challenges arose in a couple different areas. And I think a theme you're hearing from all of us is that doing a project where we're engaging clinicians and patients, and there are, clinicians on the team who are also do work in this field. We're walking a lot of lines. We're trying to balance this in a lot of different ways. So, I think some challenges arose around complexities of recruiting within a clinic to which we were professionally connected. So Alissa saw one side of this with the providers. For recruiting and interviewing the patients and caregivers, the way this manifested was, for example, we were concerned about power issues potentially where, patients, because they knew that one or more of the providers in their clinic and the caregivers knew that one or more providers in this clinic were involved in the leadership of the study, we were a little concerned that patients and caregivers might feel some pressure to participate, even if they might not want to. And so we tried to be very transparent about the pros and cons of participating. We were concerned about privacy, you know, especially because one of the co-directors of the study, co-PIs of the study at one point, was an active provider there. We took a lot of steps to make sure that there was a firewall between any patients of his on the study and what data he had access to, because we wanted to be able to, you know, very sincerely say to the patients and caregivers that, you know, their particular stories that identified them, even without their names, their stories identify them, you know, that those would not be shared with the person from whom they were receiving care or with whom they had just already developed a clinical relationship. We wanted them to feel comfortable about sharing. And we also, you know, we just felt like that was a very important line to maintain. And that was difficult to maintain sometimes because as a team, we were reviewing data together and brainstorming ideas and analyzing the data as we went. So, so that was a challenge, but I think we did a decent job at it. And, you know, there were some, in terms of recruitment, some challenges around some, you know, gatekeeping in a way where because we were asking providers to signal to us, you know, some patients that fit our study criteria, you know, providers varied in how much in how comfortable they were in recommending patients to our study. And so in some cases, and for some particular dementia subtypes, it was difficult to find enough participants. That said, we wanted to make sure that we were respecting what clinicians were comfortable doing in terms of recommending patients, and they knew where their patients were. So I would say, I'm not sure how that could be overcome, but that was a challenge sometimes in terms of getting the numbers we wanted for certain dementia subtypes. Other challenges I would say came up particularly around data collection. So we wanted to be very careful, you know, these caregivers were, the active caregivers were shouldering a ton of caregiving, obviously, and bereaved caregivers had gone through a terrible loss, and the patients themselves were going through oftentimes a difficult disease experience. And so I think we tried to do a very thoughtful job of approaching all of our activities in a way that could, you know, that maintained the privacy of our participants, the dignity of our participants. And so some steps we took to do that included, you know, making sure that we were not approaching bereaved caregivers until at least 3 months after death. We didn't want to trouble them before that point, and we often waited longer. We employed teach to goal consent for all the patients because we wanted to make sure that the patients were able to understand what they were entering into and that they truly understood the activities that we were doing. We sought to find a good balance in our interview guides when talking with patients. There were some patients that, and some caregivers where there maybe was some ambiguity around the diagnosis. And so we did not want to be the ones to share what, you know, our understanding was the diagnosis was. And so we set up the interviews to make sure that we elicited their understanding first, and we worked with whatever their understanding was of the disease and the diagnosis. We tried to be very clear about the fact that we would be discussing heavy topics with them. We wanted them to be prepared. And we had a list of resources for people who felt like they wanted some support in terms of emotional coping, and other resources for connecting with others going through a similar experience. We had a list of resources to provide, and that felt good to be able to give something back to our participants. And we also, you know, a challenge in a way was that we had decided that for most of the interviews, we wanted to conduct them separately, you know, patients for some, caregivers for others. But, you know, in the moment, sometimes patients wanted caregivers to be involved, and that was fine. We wanted to respect that, but that obviously changed the structure of the data we were collecting. And so sort of navigating that and how we report that was a bit of a challenge. I'll stop there. There's obviously a lot that we were thinking about.
Wow. So Sarah, what you just described highlights a lot of nuanced issues, a lot of complex issues, trying to navigate patients and caregivers, issues around bereavement, issues around confidentiality. I'm curious, given the complexity and sensitivity of these kinds of questions, especially as they relate to palliative care, how do you think your years of experience, you all are experienced qualitative researchers, you all have your PhDs, you have been in the work for a bit. How do you think your experience and training impacted this data collection compared to perhaps how you might have approached it, you know, as a trainee or earlier in your career?
Sure, I think that's an interesting question, and it may, you know, I don't know if Krista and Alissa will have time to weigh in on this too, but it'd be interesting to hear from them. For me, I think I would say my training really helped me to do this work in two ways. One, I felt that in the moment of data collection, if I were the me coming out of grad school, in grad school or fresh out of grad school, I think I would have been very uncomfortable, and I think it would have been a much more emotionally and cognitively different experience if I had had a lot less less experience in the field, less expertise. You know, these were emotional interviews to conduct. More so for the caregivers, I would say, than the patients. And, you know, I mean, I'm not going to tell any of you palliative care clinicians anything you don't know. You know, I think it takes a lot of training and skill to sit with someone when they're processing really deep, heavy emotions and grief, and anticipatory grief. And I just don't think I would have had the skills to do that, the emotional skills to do that fresh out of grad school. I think that is something that I have developed over the years. Also, I really had to be able to react dynamically in the interview. You know, we had the key points we wanted to get through, et cetera, but there were, you know, on the patient side, you know, it took a lot of the skills I've developed to respectfully, you know, make sure that we did get through all the parts of the interview we wanted to. And I think it helped that I had a lot of practice conducting interviews with a lot of different people with a lot of different interactional styles to do that. You know, I also think just the fact that, you know, I was in my late 30s, early 40s conducting these was helpful. You know, I remember one bereaved caregiver who had lost two spouses, one to cancer and one to Alzheimer's. You know, she looked at me after divulging, you know, some very, you know, touching and sort of grief-filled thoughts. She said, you know, I know you at UCSF, you know, you do good work and you're asking me all the right questions, but nobody in their 40s knows what I'm going through. And really, you should, you know, your great studies, you should send people who are older. And, you know, and she was saying that to me, who's like 20 years past, you know, the age of some CRCs, for example. So I do think there was something good about being a more mature researcher in the field to do this work. I'll also say that I think there were some power dynamics on the team for which it was helpful that I had a good amount of expertise and I felt comfortable in my knowledge. For example, doing that work to make sure there was that firewall between the clinicians on the project and patients who may have had contact with them. I don't think I would have felt as comfortable standing up for that as a junior researcher. I think there were a few moments like that where I think the integrity of the data and of the design process, et cetera, you know, I felt like there were some moments where it was very important that we went a particular route, and I don't think I would have felt I had the expertise nor the confidence that it was the right thing to do earlier in my career. But it might be interesting to hear Alissa and Krista speak to this too.
Krista or Alissa, anything you want to add?
Sure, I can chime in. So I think that Sarah's expertise was really evident in reading through the transcripts and one of the reasons that Sarah was on the team was in part because, and I think this is not infrequently true in palliative care, that when we have personal losses, it changes how and what research that we are able to do in person ourselves. And so it was really helpful to be able to trust that Sarah was going to be able to do a much better job than I could doing that data collection in that moment, where it could have been really triggering for me. And in fact, often the interviews were, just reading through the transcripts, the interviews were triggering, and but I could so appreciate the sensitivity with which Sarah touched on all of these topics that were really quite difficult. But her expertise was also evident in, as she mentioned, in the sort of project management of the team. And it helped that we created a team where I think there was a lot of mutual respect among the variety of members we had for the things that we were expert in. And then our willingness to say, oh, that's a great idea. That's a different way to think about it, but then stand up for the things that we thought were important. And it felt like a team where there was a lot of mutual learning from one another in all of the different ways to go about these in high quality ways. Alissa?
Yeah, it's an interesting question, Christine. I guess I'll say, my anthropological graduate work, I lived in Bolivia for 2 years doing field work, on health policy reform and traveling all over the country and spending time in community settings. So I think some of what we talked about before about, the familiarity with community-based participatory research and community engagement and, following sort of not just, I think, for our team, assuming we know what we're going to find in the data, but really following, through I use a very inductive method on kind of ground up approach to coding and, letting yourself be surprised by what you're seeing and finding, and also, really staying rooted in, whether the community you're working with is healthcare providers or policymakers or patients or caregivers, thinking of, how does, how does the context in which people live, work, think, their values, how does that shape the type of responses you're getting, and how can that be seen in the data, and how does that emerge and when reviewing the data? So I definitely think I'm always drawing on, even though I don't have the luxury of that many years necessarily on a project anymore. And I think, we're now, in the clinical research setting, a more rapid approach is often more valuable for moving ideas forward. But, having that rootedness in, that background to thinking about research has been really helpful. And yeah, I think the other thing that both Sarah and Krista have mentioned is just the value of having a good team. And I think one of the reasons I left the kind of traditional anthropological world and moved towards clinical research is I really wanted to be part of teams, and especially multidisciplinary teams, which we really had an amazing group of people with different backgrounds, specialties, kind of different stages of their careers. And I think that's just so valuable for not just the design of a project and the organization of a project, but also for how people think through the data. And I think our team-based approach to data analysis and thinking about themes and looking at transcripts was really key to, always pushing each other and ourselves to think differently about what we're seeing, and not just take for granted assumptions that we might have had about, even things like, what does palliative care mean? Like, always asking what these concepts mean, not just to us and, officially in the literature, but what do they mean to our research participants, and how are they using it? So I think having this multidisciplinary approach really enabled that kind of intellectual work, and I think is making the products better, but also the types of interventions and tools we can develop much better because of that.
Thanks, really fascinating. And I think what this highlights, among other things, is the importance of team science and the importance of having sophisticated and experienced social scientists on one's team, to do this kind of work together so that everybody is pushing everybody to think critically and also in nuanced ways about the topic areas, and to recognize that we all are coming with our own context and with our own backgrounds, and that will influence the nature of our analyses. So let's pivot just a little bit and talk about some actual sort of process related to how to do these different kinds of qualitative analyses. One of the things that's so interesting about this work has been seeing how a whole array of different kinds of qualitative analytical approaches have been brought to bear. So let's start with the qualitative portion of the chart review. And I wonder if, perhaps Sarah, you could describe the process and then how that worked.
Sure, absolutely. So at one point, I mean, this project has done a lot, and I give Krista and Christine and George Nassan, one of the former directors, a lot of credit because, I think we've done a lot with the data. And so one of the products we've produced was an inquiry into why are certain persons with dementia lost to follow-up in a specialty clinic. That really had not been delved into in the literature. And so a few of us on the team designed a project, and I believe Talita Rosa led this initially, and then Sam McFarlane and Nicole Boyd decided to look into the charts of the patients at the clinic, and we selected 61 patients who had been seen between 2012 and 2017, I believe, in order to look at the notes and see, based on the interactions, between patients and providers and caregivers, providers and patients, notes from phone calls, et cetera, what came up when there was a discussion of leaving care or when the provider or the staff could not get a hold of the patient or caregiver. And so we did this, combined inductive and deductive thematic analysis, where initially they looked through, what's coming up, what are the parts of the chart that matter, et cetera, extract those data, look at them again, come up with some clear, reasons. And then I came in on the step of trying to create a code book from that. And so really we were operationalizing, what does it mean to no longer come in for care because the caregiver does not, find it worthwhile, for example, or what does it mean that it's too difficult, or, what does it look like when they are transitioning to a different provider, for example. And so I think it was an enriching process on both sides because the team members with whom I was collaborating, they knew the clinical context, they could read between the lines and really understand what was going on. And then I was bringing the social science perspective saying, okay, how do we actually define this, operationalize it in a consistent way where three of us can look at the data together, apply the codes consistently, and then end up with the finished product of being able to characterize across this sample what are the reasons for loss to follow-up. So I would say that was like a kind of nice sort of short, and tight iterative cycle that we went through to develop that project, and I think we learned some novel things from it.
Thanks, Sarah. So what I'm hearing you say is that one of the things that you had to do once you were doing this sort of analysis was to be very clear with the entire team around definitions, and to not just code things and just assume that by virtue of naming that everybody understands what those names mean. And this is something that I often see not happening in qualitative analysis, and even in the creation of code books, that there's clarity and replicability around the definitions of what the codes are, and you really assured that happened. So Krista, I wonder if you could tell us, since you've been leading the analysis and the dissemination of the patient caregiver data, what you've learned in that process and some of the frankly different kinds of qualitative analytical approaches that you've used.
Yeah, thank you. So as Alissa and Sarah have alluded to, this was a project that involved a huge number of interdisciplinary, international, primarily fellows, postdocs, some research assistants from a variety of different stages of career and parts of the world. And so one of the things we learned is how much teaching and level setting and questioning and answering that we needed to do to get everyone on the same page. And it probably made the process longer, but I also think it made us much more certain that we weren't, it felt like we had people checking our biases all the time. And as somebody asked in the Q&A, where did we come across disciplinary differences in thematic analysis versus content analysis? Some of it was making sure we were reading the same literature or, reviewing some of the same methods papers, but some of it was saying, let's be really clear and document what exactly we're doing at each stage of the way and worry less about the jargon and more about being transparent and replicable and rigorous in how we're approaching this. So sort of taking a step back, as we were doing data collection, we were doing debrief sessions with this huge team. And it was really interesting to see what clinicians were surprised by. We were interested in sort of how the narratives impacted or moved them. We added supportive infrastructure. So as people came in and out of the project, we were able to get them up to date. And of course, the pandemic has, of course, drawn out our analysis process. So I am really grateful that we put that time in as we have onboarded new people onto the project. We used, the main thing we're analyzing are these 30-page, 30-minute to 2-hour interview transcripts. And we are using structured notes and memos, which were 3 to 4 pages long, to capture those main details and some of the interviewer reflexivity. I thought this went well, this is what it felt like, that kind of information. And then we also created these Excel summaries of the data set that had like a little blurb about the participant and key information of interest. And then we've created PowerPoints with the summaries of the project and what is the problem that we are trying to address with our analyses. Another thing that we've learned along the way is to keep the coding simple and code for each paper separately. And as Alissa alluded to, she has a very inductive approach and ends up with a lot of codes. And I've used that method as well, particularly in my dissertation work where I was the only one coding the data. And so if you're able to do things differently when you're the only person analyzing the data than when you've got other people coming in and out and checking your work and asking, what do you mean by this? How do I apply that code? And it makes you really step up your game in terms of how do you create code books that are usable for other people, and when are you talking about using a deductive approach and when do you use an inductive approach? Sarah and I went down a rabbit hole of trying to deductively apply the National Consensus Project for Quality Palliative Care clinical guidelines to our data, developing all of these inductive codes and then saying, nope, this is way too complicated. We're gonna start over. And we went with, what are the challenges that were empirically described? And we stayed away from anything implicit. It had to be something very easy for anybody on our team, again, international team, to identify as a challenge. What were their helps? What were their, or what they thought would be helpful, what they said was actually helpful, and really just sort of narrowing down to 7 to 10 code sets at a time, and then sort of applying those, refining them, getting it solid, and then going back and developing another set of codes if we wanted to go into more detail, and really going back and forth thinking about, well, what's our discipline? What's the journal we're targeting? What kinds of presentation of data are they looking for? How are we making sure that we write down all the things that we think are important, and maybe putting it into a methods appendix, but then making sure that the reader has just the small bits of information they need along the way. And we've also, I feel like people often talk about, well, I've got to work in Atlas or in vivo, but we found that particularly when you're working across people in multiple institutions, they may have differential access to software, that going straight to comments in the Word version, Microsoft Word documents of transcripts, and then trading back and forth by investigators and commenting to help refine the code book was really helpful. And then if it was going to be useful to have a systematic output, which there's almost always a place in some analysis where I wish I had it easily outputable from Atlas. Moving into Atlas is the one we've typically used at UCSF. And then we've also been having the team write 2 or more papers in parallel with different first authors, which has the advantage of having multiple people immersed at the data at the same time and being able to check, this is what I'm getting out of it. Did I get it wrong? How did I get it wrong? What's the disconfirming data I missed? And that's been really helpful. We've also been giving our team members really thick versions of the table if they're not able to get immersed in the whole data set with us, because it is pretty large. So we'll give them multiple quotes per sub-theme, for example, in a table as we're giving them an outline of the manuscript. And that lets them sort of both check our work as well as help refine our organization and presentation of the data. And finally, we have been playing around with using figures to help visualize the data, the themes, and thinking about other ways to present the data to make it more efficient, more interesting, engaging.
Thank you, Krista. So I wonder if you all could talk about some of the similarities and differences in your approaches to this research study, as there are, of course, many different ways to engage in transparent qualitative studies.
I'm happy to take a first stab. I think we've highlighted a little bit ways in which we vary in our approaches in terms of styles of engaging with the data. Alissa often likes to really start very inductively and code a lot. I tend to like to sort of scope my question more narrowly, and sort of do a combination of deductive and inductive depending on the research question. Often I find that helps me focus on analyzing the data. It all depends on the research question, of course, but I think we're very, despite those different styles of initial engagement, I think we are very similar with regard to something Krista just said, which was, we all come from traditions where there's a very serious engagement with critically reflecting on one's own analysis and one's own practice of research. So, I would say it's actually easier to do this as part of a team than to do solo work. So when we're in the data and we're exploring it, or we're doing a more directed analysis, we have at this point across the 3 of us a lot of practice, but I think we all consistently, and will for the rest of our careers, engage in that practice of asking, what did I miss? Did I make an assumption here? How could this be explained otherwise? What is the counterfactual? What, if there's a different mechanism at play, what would that look like? And then go look for it. So I do think we're similar in that regard. And I hope that's something that, we brought to the the Dementia Palliative Care team, was this real critical lens in terms of making sure that, as we engage in this rich, complex data where you can go down so many different rabbit holes, that, no matter what we're doing, we're checking back and we're making sure that the analysis we're doing is rigorous.
Thank you. That's so important. And I think that sort of critical, ongoing sort of critical reflection and asking for critical feedback from others is, again, something that we often cannot do in qualitative research, but is so important to do. In the interest of time, I want to ask you one final question that I think is incredibly important to our audience and important to all of us as we think about the future, which is we are all increasingly being sensitized to and hopefully activated by what we're seeing around healthcare disparities and structural racism. And I'm interested in how you think these kind of qualitative methods could be used in that setting. I think, some of the things that you brought up earlier around the importance of rapport building, relationship building, authenticity are critical issues, but are there other issues that are important, and how could these qualitative methods be used to address and explore issues around structural racism and healthcare disparities?
I can jump in. I mean, this is a huge question with, we're still very early on in figuring out good answers and how to do this type of research in a way that really addresses the needs of populations who have been traditionally left out of research or misrepresented or not had access to healthcare and things like that. I'm doing currently a big research study in the safety net setting throughout California, interviewing primary care providers and patients and caregivers about the experience, and kind of earlier in the stage, so not the palliative care phase, but like it through the experience of, receiving a diagnosis or the diagnostic workup, and then kind of immediate care after that. I think that it's definitely involves a lot more of the on the ground work. I luckily had the ability to visit a lot of my sites right before the pandemic started, so I'd already formed some relationships with the health systems that I'm working within. But also, I think being really humble about what the researcher does and doesn't know, and always asking questions, what am I missing, or, what is your experience? I think qualitative research can really enable people to tell their stories. And if, I like to use open-ended interview questions to give people a lot of chance to, take the tangents that a survey might not enable them to, that we might, consider a tangent, but that are really important. And I ask questions about, who they are, what their experiences have been, not just with the healthcare system, but, just as humans in the world. And I think, for me, part of the power dynamics that exist with research and with the healthcare system around that have built up these inequities over, history, if there's a way to use this approach to research to start allowing people's voices who have often been silenced or not, not heard or really marginalized to have a voice. I think that's one thing that this method can do if it's, and constantly like learning how to do that more sensitively and more carefully, but really just stepping back and trying to let people tell their stories. I think that's really important. And that's, both clinicians and people in the healthcare system. But yeah, I think it's something that I struggle with, ask myself, how can I do this better all the time? And I'm constantly looking for more training and reading and things like that. And I think also just making sure that your research questions are also informed by people who are living these experiences. And so, I might go in thinking I know the right question to ask, but, always asking people to participate in helping me think about what are better questions that would actually address the needs that people have.
Thanks, Alissa. I really appreciate that. Both talking about vetting your questions as you develop your question guide, vetting that with the relevant stakeholders and your partners, your research partners, and then being thoughtful and curious and making sure that the stories speak. Those seem like incredibly important issues to address. And I'm wondering if Sarah or Krista, if you have anything you'd like to add.
Yeah, I mean, I'm so glad you asked the question, Christine, and I'll just quickly add, I think, I think the challenge that faces and the opportunity that faces us as qualitative researchers to address health inequities and promote health equity and include historically, excluded and historically marginalized people, in the research and in the benefits of the research. I think it's the same across the board in terms of, projects have to engage that goal from the outset. It's very hard to do that successfully in the middle of the project or once you're analyzing the data, really building it into the design. And part of that is also bringing in individuals with lived experience, from the outset to help design the project, to help refine the research question, help refine the study materials. I'm running a pilot right now where I have 4 community advisors with lived experience of the phenomenon we're studying. And it's incredibly enriching, and I'm learning a ton, and the project's much better for it.
Thank you. So, Krista, anything you want to add before we move to the questions and answers?
No, I not worth spending time on.
Thank you. So I wonder if I could turn it over to you, Krista, to facilitate our question and answer session.
Absolutely. So we wanted to note that as members and Sarah and Alissa are co-leaders of the Medical Cultures Lab at UCSF, we are building resources about qualitative data collection and analysis. So you're welcome to ask questions about our specific project, but also just share with us, what do you wish existed in the world to help you in your own analyses? I always think that qualitative methods and palliative care make a really strong partnership. I think they're complementary approaches to the world.
I think we did have at least one question in the question and answer. I wonder if one of you all could take that on.
Sure. So one of our participants said they were doing a nursing PhD program and an MPH program concurrently, and noticed that the MPH qualitative research class focused on coding and thematic analysis, whereas the nursing qualitative research class instructor didn't consider thematic analysis as a qualitative methods and suggested instead a content analysis. And the participant asked if we had encountered similar situations. My response was, yeah, I think there's a lot of different disciplinary approaches to qualitative analysis, or what people think are acceptable or preferable. Although I feel like over time, there's some closer consensus, or at least in the applied clinical research world. But Alissa and Sarah wondered if you wanted to weigh in.
I think this is one of those situations where the jargon and the sort of named labels of all these different analytic approaches kind of gets in the way of our really communicating with one another about what we're doing. And in the Medical Cultures Lab, I think some of us in our discussions have really backed off from naming things and just said, like, first I went in the data, tried to be open-minded, I was reflecting on what I had read about this, So, yes, I'm definitely familiar with debates like that. I also think it really depends who you're reading and whose term you're using regarding what is content analysis, what is thematic analysis. So I think, and I would hope that, this is true for reviewers and people doing the research, that it's much more important that people be clear about what they actually concretely did than what name it is. I'd rather have a clear explanation than a name, and hopefully that can solve some of these challenges.
Excellent. I love hearing this from 3 really sophisticated qualitative researchers, that essentially a lot of times we get sort of parsing hairs and embroiled in semantics and don't pay attention to sort of the larger and important questions that are, what is the data actually telling us? So thank you for that.
I mean,
Any other, go ahead.
Frankly, I feel like I think I've been doing qualitative research for 15 years now. And every time somebody says I did thematic analysis, I check their citation and I go reread the paper to see if I can figure out what they actually meant and if they did what they meant.
Well, that actually relates very well to a question just posted by Jane Lowers around quality in qualitative research and issues around replicability and addressing quality concerns such as saturation. This is something I know we've talked about a lot. I wonder if you all could speak to this.
Well, yeah, I think, I think the team approach that we've described is one way that we, describing the kind of iterative process of coming to, coding, then coming to agreement about terms in the code book, having multiple coders that end up kind of coming to agreement and resolving disagreements. There's a lot of ways we describe what we do that is very iterative, that I think we've all had success with the clinical journals when you kind of figure out the best way to simplify those steps, but just explain that that you have done a rigorous process of making sure that it's not just someone's subjective view on the data, but that it's actually, been agreed upon by a team of experts. And in terms of saturation, I mean, I think personally, I reach saturation in that I see the same things coming up and there might not be new codes added, but I never stop coding interviews when I reach saturation. So it would feel like a loss to not bring in the rest of the content that I've collected. So I don't know Krista and Sarah's take on that, but I think it's a term, again, that journals look for as a way to kind of indicate that you've done the due diligence with your qualitative analysis. But to me, it's more important to treat the data with the integrity that I want to get what I want out of it, and to review it in the way that I feel is like respectful to everything that I've gathered. So I kind of will use those terms as needed and reach the kind of milestones that journals need, but really have my own process for making sure that I feel comfortable that I've, gotten to where I want with the data and that my team agrees with that. And, different people do different things. I'm working for the first time with kind of this really formal inter-rater reliability process, which, I think there's a lot lost when you try to get to the level where you can calculate things like that. And so, it might be useful just to figure out, are we agreeing on certain things at the higher level, but then the depth work that I personally like to do with the data involves a lot more of an iterative, complex process. I think knowing your journal, knowing the audience is really helpful, like figuring out which journals really understand and like to publish qualitative research, and looking at how people have written